My first reaction is, wow, that gives us quite a few issues to discuss this evening. And of course, we don't have an infinite amount of time, but we have a terrific group of folks to discuss the issues with you. I won't take a lot of time to introduce them since you have their biographies in the pamphlet that was on your seats. But we're really pleased to be joined this evening from, on my right, far right, Rebecca Martin, who's the director of the Center for Global Health at the U.S. Centers for Disease Control and Prevention in Atlanta. She's worked extensively, both domestically and internationally, on the kinds of issues that we just saw described in this terrific film that Matt King and his colleagues have produced. And she now leads CDC's global efforts to improve health through science, policy, partnership, and evidence-based public health action. Next to Rebecca is Jim Jones, who's the executive director of the ExxonMobil Foundation, where he oversees their grant-making programs in global health, women's economic opportunities, and U.S. math and science education. And Jim has a long and distinguished career in a number of roles, including having been executive vice president of what's now the Gavi Fund. ExxonMobil is also a member of the private sector roundtable of the Global Health Security Agenda, and I'm sure we'll come back to talking about some of those issues. And then finally, to my immediate right is Chris Collins, whom you'll recognize from the film we just saw. And Chris is the president of Friends of the Global Fight to fight AIDS, TB, and malaria, where he leads efforts to educate and engage U.S. decision makers on the Global Fund's life-saving work and its effort to end the epidemics of AIDS, TB, and malaria. So, I think that the Global Health Ending Pandemics, the film we just saw, did a terrific job of laying out the broad range of issues and the relationships among health, security, and development. So it gives us a rich menu of issues that we can pursue. And there are a few in particular that I'd like to try to come to, but let me just start by asking Rebecca, given that range of challenges, what do you think are some of the areas where we're really making progress? And how, describe for us how the U.S. government through CDC and other agencies works with partners around the world to continue to address these issues.
Thank you, and thank you for being here tonight. It's great to hear it. I think I could be one of those. You're going to turn this on, maybe.
Yeah, just push that up. Yeah.
Got it. I could be one of those. We always say that a disease can travel, infectious disease can travel from any village to any metropolitan city in 36 hours. I just came from Atlanta. I'm in New York, and I'm going to Kigali tonight. So, there's the real possibility that these things do fly around, and it is possible to have this happen. I was reflecting and hearing Stephen Morse talk about the 1918 Spanish flu. It really was the same challenges that we're facing today in terms of looking at when something is detected, how fast it's detected, who reports it and when. Do we have diagnostics to be able to test it? Do we have laboratorians who know how to do that? And then do we have vaccines? Do we have therapeutics to be able to fight that? And all of those things played a huge role in the continual spread of the Spanish flu. And I know many of you know, but it's called Spanish flu because Spain was the only one that reported it. Happened in the US, France, but nobody wanted to report it. And I think that's part of the issue is when we're not reporting and disease is spreading, the importance of making sure that we can stop diseases where they occur. So looking at some of the challenges that we're facing today and how we can address those, we have made a lot of progress in this area, and it's really exciting to see some of the progress that's been made through the importance of having partnerships. It's no single entity, such as a country or one single institution or organization or one sector that can have the global health security to have that protection that's needed to stop diseases where they occur. And we're seeing more and more multi-sectoral partnerships that are forming, and the value of those to be able to move and to stop diseases, but also the importance of being able to sustain, as we heard from Damiso Moyo in the movie as well, the importance of being able to sustain what we're doing. We are not done what we're doing. There's still an urgent need. Many people, after an epidemic occurs, forget about what happened and they move on to the next one. And we spend a lot of resources on the response. but not on the prevention. And this is the first time in a long time that we've seen investments being made in public health infrastructure, in health systems, and the excitement of this really carrying over. The engagement of bringing in the private sector, I think, is manyfold in terms of looking at the multi-sectoral, the advocacy, the voice, the influence, but also the innovations, the flexibility, and the science and technology that comes with that. And I think working in those partnerships, we've worked with ExxonMobil in Nigeria during the Ebola in 2014 for infection prevention and controls efforts. We have many, many different private foundations and partners that supported establishing incident management systems where the government could lead, bringing together the sectors to respond to outbreaks. And these have withstood time. But it's not a one fix or one time. It has to continue. We must continue to move forward and make sure that we can stop diseases where they start. And that's the best way for us to be prepared here at home as well.
Thanks, Rebecca. I think that gets us off to a good start. And just picking up on the comment you made about partnerships and the role of the private sector, let me turn to Jim next. And I haven't been used to, and most people here don't think of ExxonMobil as a health company. Obviously you're involved in another area for your core business, but just tell us, why does ExxonMobil think it's important to invest in global health and in health security, and what sorts of capabilities and resources do you bring to those issues?
Right, so ExxonMobil is not a health company. Let me tell a story and maybe get to your question about, as I get asked this question for the better part of the past decade, why is ExxonMobil so heavily invested in global health, especially in the fight against malaria? And as Rebecca mentioned, our collaboration on the Ebola crisis or potential crisis in Nigeria, it's good times. In 1999, when those two companies merged and made, at the time, the largest merger in the history of the world, our footprint as a newly expanded company was greatly expanded, especially in malaria endemic countries. And we were involved at that time in the construction of a pipeline that went from Chad, which is a landlocked country, to Cameroon, to the sea. At the time of that construction, the #1 cause for loss of productivity was malaria. So those are the kind of things, and Jeff, I think you'd appreciate this from your former life, those are the kind of things that reach the C-suite, and CEOs sit up and take notice and say, we have to do something about that. So what began, actually, in kind of a strange way, was a community program on mitigating the effects of malaria on our workforce and our contractors before our inside the fence line program started. So we started investing first in communities, which is usually not the way corporate kind of philanthropy works. I hate that word, but how corporations work in communities. It's the business driver that made all of this imperative. If Ebola had emerged as a serious health concern in a West African country in which we have 5,000 employees, we were perplexed as to how we were going to guarantee their own health and safety, let alone their families and the communities in which they work and operate. So these kind of issues are vitally important to the private sector. And so let me just get to one other point on this in terms of the private sector. And Rebecca kindly mentioned a lot of these things. And I have my little corporate cheat sheet here. It's really kind of not. If you knew me, you know I don't adhere to much corporate stuff. So, I was just jotting some notes in terms of what we do at the ExxonMobil Foundation, how we work with partners, and I know some of the folks that we work with are in the room. We obviously provide funding, so I don't want to minimize that and say that's not important. Of course, money's important. So whatever follows and what I'm about to say, don't think I'm minimizing that. I know that the money's important, but you'll have to remember that there's no way that the private sector can even make a dent in terms of the donation of what bilateral governments make in terms of their donations. So the money's important, but the money's not everything. And I think too often our partnerships don't tap into those core competencies of what make us successful and what we do best. And just off the top of my head a second ago, I was just watching the film and making some notes about what we do. And so this isn't hypothetical. This is a daily occurrence. We help our partners with data collection and surveillance. We analyze data every day in various parts of our business. We help with project management, advertising, marketing, government relations, both here in the United States and in developing countries. I think anybody in this room could acknowledge that the constituency among elected officials that we may be able to access in the United States government, for example, is vastly different than others can do. We've helped with chemical engineering. We help with risk assessment. We've helped some product development partnerships understand how you pick winners and losers, how you move forward on a project, when you have to cut a project off. And to a large extent, we help with capacity building. And I know this isn't the sexy part of global health, but to me, it's really the most hopeful part. It's the part where I deal with people in endemic countries in terms of training, building up their diagnostic skills, helping people understand that there's a bigger picture beyond their one clinic, and helping improve the skills that people deal with their patient base. That to me is really the thing that gets me up in the morning and makes me really excited about going to work. I know some of this stuff is really important, and I have to say, I've never seen, even though I was the first employee of Gavi, I've never seen a film that used so many injections as this one, because we were always told don't show those things, it skeeves people out. But I know that that's the really kind of sexy part of this. But let me say this, I think that film is terrific. I really do. I think it's an amazing film, and somebody who could, kind of a group of producers who could kind of incorporate all of those themes in 28 minutes, I think is really important. We saw really terrific spokespeople from governments. We saw great people who lead think tanks. We saw celebrities. We saw some really amazing military leaders who you generally don't hear in this space. We saw people who lead think tanks and advocacy organizations. We did not see one person from the private sector. And I don't know if I'm the only person in the room who noticed that, but there isn't one business leader who was interviewed on that. So what I say to you is, too often the private sector is overlooked as a funding mechanism, and too often that's at the peril of the partnerships I think that Rebecca was talking about are so vital. So let me just say that. It's not a criticism, I'm just saying it. But it's really a good film, but it's something that we need to be cognizant of as we work through these issues.
Terrific. Well, I'd like to ask Chris to comment on that too, because Friends of the Global Fight just issued a new report on U.S. leadership in fighting the three big epidemics of AIDS, TB, and malaria. And so two questions. One is, you highlighted the opportunity for more partnerships with the private sector, the point that Jim and Rebecca also spoke about. So you might want to say another word about what opportunities there are there. But also, I'd like you to comment on the question of why U.S. leadership is so important in the fight against not just the three epidemics, but in global health more generally.
Yeah, and thank you for bringing us together tonight. I've been at Friends of the Global Fight for a year and a half, and we just realized that if we were going to be successful in making the case for U.S. investment, we really needed to forge closer partnerships with a lot of different communities that we felt really could be heard in Washington. I spent a lot of my career paying lip service to the idea of partnerships with people who had a different worldview or experience than myself, but I hadn't done a lot about it, frankly. And we realized we just had to get out of that echo chamber and grow the people involved and support other people in being advocates. So private sector, for sure, we've created an informal group of private sector organizations. Jim was just great. One of the people that came down to Washington last year, we went to Capitol Hill, talked to appropriations staff. That story that Jim just told, is so powerful for a staffer on Capitol Hill to hear, because they just get it like that. They understand. I've actually retold that story about 100 times since we had that day on Capitol Hill. But I think to what Jim said, we're just going to have to keep thinking about it and talking with each other about how to work together, because there's no way that all our development goals get achieved without more integration of the NGO and the private sector and governments and others. We've really got, and in the area of health, we're talking about these three epidemics, We need better technology, but so much of the issue is scale and just achieving scale and delivering things that work in an evidence-based way that reach everybody. And we're just not going to achieve that scale until it's an all-hands-on-deck enterprise. Jim speaks to the expertise piece. That's with the Global Fund definitely true. They have a whole variety of partnerships. Coca-Cola is one of the better known, their last mile initiative, where, as we know, people are drinking Coca-Cola all over the world, and they're able to get that product out there. How do they do it? So what they're doing is helping the Global Fund with supply chain management, with getting staff to learn how to quickly repair refrigeration devices, this sort of a thing. But that kind of expertise, the Global Fund works with a whole variety of companies. PEPFAR is growing in that area too. Then I think we need to be talking about something that you work on a lot, innovative financing, and the whole financing picture in global health is changing. So I think global health advocates need to be educating ourselves about that. I don't think private money is a panacea at all, but I think it can play a role. And I think that aid organizations can be catalytic in bringing that money in. And then advocates. I just think there's just such a huge role for companies to play in terms of being advocates with their own governments, and then also reaching people that work in those companies all over the world to play a role on the ground in those countries. So there's a lot of things I feel like are yet to be explored between sort of the donor, government, NGO, and private sector in terms of all working together. The faith community. Same thing, when we're trying to do that too, really build ties to the faith community as advocates, but they're also as providers. U.S. leadership. So we did just come out with this report called At the Tipping Point. We have copies here if you want any. I can get them to you. But it's basically making the point that as a matter of policy, the only thing that makes sense is for the United States to say that we're dedicated to not just funding fantastic programs against AIDS, TB, and malaria, but in fact, to marshaling others in the world and with our own expertise, moving towards ending those epidemics. Not just saving a lot of lives, but bringing an end to the epidemics of AIDS, TB, and malaria. We're not on track to do that now. There have been great accomplishments in terms of reduced mortality for each of these diseases, and particularly in malaria and HIV, you've seen real progress. But the mortality and incidence is falling too slowly. We saw an uptick in malaria cases in the last year. We're seeing drug resistance in each of those diseases. If we tread water on these responses, we're looking at resurgence. That's the history of global health. And so I think, and the other thing, and this was actually somebody said in the show, is that it's going to take more resources from other donors, certainly from implementing countries themselves, from the private sector. But without American leadership, this doesn't get done. And actually, the reasons I think were ticked off in the movie. We bring considerable resources, but we have in NIH and CDC and all these agencies incredible expertise, people who've given their lives to learning about how to fight these epidemics. There's no other country that has that kind of expertise. And then also I think the strategic sense that we bring to a lot of the problems that we try to address is invaluable as well. So I think we have a critical role in terms of rallying the world, other donors, implementing countries, private sector, et cetera, in getting the job done on these diseases. But we need to lead on it.
Jeff, can I add to that for 1 second? I think this point that Chris made on resurgence is really important, and if there's something that scares me, it's that, about losing leadership capacity and taking our foot off the accelerator in terms of progress that we've made since the year 2000 in many of these disease categories, not just the big 3 diseases, but across the board. And since today is World Malaria Day, let me use malaria as an example. Justin Cohen at the Clinton Health Access Initiative did a fascinating study which proved, like so much in academia does, something that we all kind of knew from common sense, but proved it empirically, which is when there's an interruption in malaria prevention programs, whether it's indoor residual spraying or bed net usage or treatment provision, malaria not only comes back to the level it was before very quickly, but comes back in a much more pronounced way. And now I think, and this is what scares me, now I think that's, And if you haven't seen those graphs and those charts that Justin did, I encourage you to look at them because they show in a visual form something that's very frightening. But do you need to get that, Chris? If anybody wants to go to the bar, go ahead. What really frightens me is that in a lot of countries in Africa and sub-Saharan Africa where we've either eliminated or close to eliminating malaria, it doesn't take long for people to go from a semi-immune state of being able to deal with a malaria infection to a non-immune state, the same way that most of the people in this room, I assume, are. So if malaria comes back to a place that has basically gotten rid of a large degree of the parasitemia, you're going to see a resurgence of malaria among a non-immune population. And that, to me, will undo not only all the progress that we've made, but go way beyond what we've seen at even the 2000 levels.
Well, that's not exactly a reassuring prospect, but it's an important point to make. Rebecca, could I just ask you to go back to, you talked as well about the importance of surveillance and prevention as well as responding to these epidemic threats. Could you just say a word more about the Global Health Security Agenda and the way that CDC is working with partners around the world to address those areas of surveillance, prevention, and response?
Sure. So the Global Health Security Agenda was launched in February of 2014, and it was actually before the big Ebola epidemic hit, but it didn't get a lot of news. It was a quiet day, it was a snowy day, government was closed, but it still went on and launched. And then afterwards, when the Ebola epidemic was just continuing and we were seeing the effects, people realized that there had to be money put towards strengthening the public health infrastructure. These countries have health systems. They were taking care of people in their health systems, but they did not detect the Ebola virus. And they weren't able to get a response in time. So even having a semi-functioning health system in some places, still without having that public health infrastructure, you can still miss it. And so the agenda, to date, there are now more than 70 countries that have joined the agenda, and it's really to accelerate countries' capacity to achieve the international health regulations. So it's a real coming together, but it's not just about the money, but it's also bringing the resources. And within that, the U.S. government has made a commitment for 5 years. It ends in fiscal year 19, so September 2019. But there was a $1 billion commitment to support building public health infrastructure in 17 partner countries that we work with. For CDC, we've been working in the technical areas of primarily looking at how to strengthen surveillance systems. So how do we have the system that can, when you detect something, it can be reported, and it can be reported in a timely manner. There can be the laboratory diagnostics, so we work on building laboratory capacity, and that's done through many private-public partnerships we have with private sector as well to make sure that we have the laboratorians in the laboratories at all of the levels in the national health system. And then what we call the disease detectives, which are the front line, the people out there who are doing the surveillance, who are looking for the abnormalities, looking for the increase in acute fevers or incidence of fevers, and understanding of what's happening and reporting that. And we've actually, just to give one example, in Vietnam, linking community-based surveillance with the national health system and the emergency operations center there, the community has detected about 371 events. They said, this is just not normal, we normally don't see this. And of those, 41 were real outbreaks. There was an outbreak of diphtheria, meningitis. So they've been able to detect these, and that is really important. So having the disease detectives on the front line, having a system of reporting through the surveillance, having the laboratories that can detect and that have the tools and the capacity to detect, that's the important part. And then making sure that we have, when there is a need to be a response, we have incident management systems so the government can lead, but bring the multi-sector, bring the animal health with the food, with the health sector, with the military if needed to be able to respond to those. So that's been CDC's. We've been primarily focusing in those areas, linking it with, I have to say, immunization, because it's also World Immunization Week, so I have to bring that in. And also working on the antimicrobial resistance. I think these are the 7 sort of key focus areas. But in collaboration with USAID, we work in animal health, and that's been a strong collaboration on the country level. And then Department of State has a key role in the advocacy and the diplomacy, and then with USDA bringing in the food and animal health as well. So it's been a real all one of U.S. government coming together, bringing these specialties and the core skills of each of these agencies together to be able to work in this. And so it's been very powerful that way. We have, as we've talked about, and Chris mentioned the U.S. government leading, or the U.S. leading. It has been that effort, but we have seen other nations step up and to be able to leverage other funds. And not only that, but we heard throughout the video the importance of interconnectedness. And I also want to say the word interactive, because I feel it's really strong about how we've built on what PEPFAR has been able to do in countries, what PMI, and how we can capacitate and ensure we have the laboratories and the systems, we've got the surveillance, and we've got the frontline detectives. So this is where we are to date. As Chris and Jim have both mentioned, it's not over, and we need to make sure that it can continue. There is a real threat that if we stop this now, it will roll back. We've seen that many times, building capacity, and it's not sustained. But the sustainment has to come from domestic resources as well. And it also has to come from different sectors in a country that we've talked about, and then different donor partners working together. So I think it's a really exciting time. In October of 2017, it was extended for another 5 years, the agenda, through 2024. And currently, the U.S. government, we're going through a process to determine what are going to be our terms of engagement and understanding a little bit more about what we're going to be working on. So that's still in the works, but I think it is exciting that there's the commitment still to continue the agenda and working on global health security.
Well, thanks. And that, you just remind us, all 3 of you, from the remarks you've been making, that we always hear about living in an interdependent world. That's certainly true, and that came out from the film as well. But I think the interconnectedness that you were talking about is also important, because as I was listening to the film, I began to think, gee, there's this litany of, it seemed like endless numbers of problems that people were trying to address. But it's precisely because the global health security agenda, the U.S. government working with its partners, you have the private sector, you've got NGOs and faith-based communities working in a coordinated and interconnected way, that we have some hope of addressing these challenges. And I'm glad you also pointed to the importance of having resilient health systems at the national level, because ultimately, the one thing I agree with Dambisa Moyo's comments about is that we can't just continue to expect that rich countries will pour money into poorer countries, and that will be a sustainable response. What the sustainability will come from countries taking these challenges on themselves and working with partners to really create resilient systems. And as Michel Sidibe noted, we're seeing more of that. So that's actually a cause for hope and encouragement. Now, I'd love to listen to these guys talk for hours, but we don't have hours, and I want to give you a chance to ask questions and make a comment or two. So we have about 15 or 20 minutes. Is anybody who would like to speak? Emmanuel, go ahead. Do we have a microphone, Lauren? Or should I just hand this one over? Okay, well, or shout. That's it.
Thanks a lot. So there's a million things to say.
Thanks, Nina.
Sorry, if you could. Movie, but,
Oh, and please introduce yourself for the rest of the group.
sorry to make a pregnant woman run. I'm Emmanuel Darcourt. I worked for many years at the International Rescue Committee and now work with Vital Strategies. So, like Jim Jones, I like the movie, but there's, my pet issue wasn't fully put in, and that's the issue of politics. So it definitely went into the politics in the U.S., but there's some arguments that on both sides that, politics on the local side, so to speak, have a huge role, and that some people would argue that the Ebola response was much less effective than it could have been because of an inadequate understanding of those politics. And also, for example, that the US military and AFRICOM in particular has an enormous role in countries like Mali or Uganda that can interplay in positive or negative ways, and that's rarely discussed. So my question actually is specifically for Jim Jones, because I know that Exxon has investments it needs to protect in those countries. And I'd be curious to know if, I don't know if that's a question you're allowed to answer, but how Exxon thinks about the politics of the countries in terms of global health and how to deal with them in a way that benefits everybody.
Let's let Jim think about that for a moment.
Yeah, that's nice.
Another question or comment?
Hi, Carmen Villar with Merck. Rebecca, how much, when you said the commitment was made to extend the global health security agenda, how much money was committed to the extra 5 years?
Okay, so Rebecca will recall that number.
She's computing it.
Here, let's go. We'll take two more and then go back.
Or do you want to?
We'll follow. Okay, and then Jeff.
Yeah, sorry, but just, sorry, Mary Foote from New York City Department of Health. Along with the global health security agenda funding, sort of how, I guess, is there a plan or kind of movement towards, helping, so we do the assessments, you kind of figure out what's wrong, there's a little bit of funding here and there to help implement, but movement towards getting more towards the implementation phase to close those gaps and mitigate.
One last question.
Great, thank you. I'm Jeffrey Smith from JPIGO. I wonder if you could speak a little bit more about your view on this idea of mobilization of domestic resources. I think this addresses some of the sustainability question. It also addresses some of the local capacity building and the local institutional development. So I think we do a reasonably good job, evidenced by this, of bringing together various different sectors and communities on this side of talking about what we would like to see in countries. But I would love for you to speak a little bit more about those same kinds of robust communities in the countries that we're all trying to focus our attention on.
Terrific. All right, well, that gives us a nice menu of questions and comments to respond to. So, Jim, do you want to start?
Sure.
Chris here.
So my responsibilities at the company obviously are grant making for global public health, specifically in the fight against malaria. But I'm an ExxonMobil employee. We don't have anything called the ExxonMobil Foundation that pays me my salary. I'm a fungible employee. I could be asked to do anything in the company. And for that reason, largely, we integrate really closely with various parts of the corporation, right? So I'll work really closely with our chief medical officer, Dina Buford. I'll work really closely with our international government relations teams on what's happening, our socioeconomic groups that assesses needs and risks in various countries. And we will coordinate responses on global health issues that obviously take governments into consideration. Jeff started this by introducing me and saying we're not a health company. We also don't think it's really our role for our shareholders to take care of the malaria epidemic in the world, right? So we think that's the provenance of the public sector and the provenance of governments. So we'll obviously work really closely with governments in terms of making sure that the national malaria control programs have what they need and helping them meet their needs. And we touched on this a little bit in terms of the collaboration that we had on the Ebola crisis in Nigeria. We built facilities because we didn't know what was going to happen in terms of, if that one guy in that old school epidemiological tracking didn't actually trace all of his contacts and that virus was unleashed into the city of Lagos, which is enormous, right? 18 million people. So we started to build facilities, all of which are now been turned over to the government of Nigeria. So we coordinate pretty closely with all those governments. Does that answer your question? Kind of?
Well, it's not an answerable question, but
He's just testing you.
It's interesting to me that you are coordinated with those arms of the corporation that does that kind of intelligence.
Very much so. And I'll give it to you to GHSA.
I just think on the political, I mean, even where we decide as CDC to where we're going to work, I mean, yes, the risk is important and the burden of disease, but it's also where we can work. But then we get involved such things as like polio eradication. And we're in 3 countries remaining. We have Nigeria, Afghanistan, and Pakistan, where we have Boko Haram and we have Taliban, and there's current outbreak of vaccine-derived poliovirus in Somalia. So we've got Al-Shabaab too. So it's these things that is how do you work and how do you think about this is really important about bringing in the United Nations and thinking about also other sectors to really think about how to reach the populations and how best to do these days of tranquility. But it is a very difficult question. To Carmen's question about the future funding, while there's the U.S. government commitment to global health security agenda through 2024, right now there is in fiscal year 19, with the president's budget, there is proposed $59 million for CDC to continue the work. But right now is the time. There's no funding currently planned beyond fiscal year 19, so September 2019. But we are working interagency as well to think about what should be U.S. government itself engagement and what should that look like. Where there's no commitment right now in terms of funding, but in terms of leveraging what we've done, finishing what we've committed to in the 5-year period, or what we're working on currently. So I'll mention that. And then to the question about where to engage in terms of implementation and starting, most of the countries have started to conduct what's called a joint external evaluation, and it's an independent assessment to identify the gaps in the areas of prevent, detect, and respond. And from that, it becomes sort of a cycle where then you start to look at developing your national action plan for how you're going to address those gaps. And then you have to find funds to cost those gaps and how you're going to close them, and then the implementing, and then do the cycle again. So we are seeing, and this is where it's so critical to have the private sector, to have academia, non-governmental organizations, civil society with government, looking at how to close these gaps together and understanding who can do what, where, and looking as well, as I said, the interactive of efforts that are out there, how you can build on them as well. So countries have done this. They've started to cost these. They have started to close these gaps. Many of them will pick priority areas there's 11 different technical areas within this. So some will say, well, we need to work on our biosafety and biosecurity. We need to work on our antimicrobial resistance, our medical countermeasures. So they'll pick the ones that are most highest on their list of priorities and start to put their funds towards that. But coming together, and we need to do more of that going forward. And now I forgot the last question from Japai. Oh, I wish I had the answer to that. I was going to ask Jeff and Chris to answer that. But I can tell you, one of the things I have seen in Nigeria, which is really exciting, is there's a private sector health alliance and working with the government, and they've come together to try to find ways to do innovative financing in countries, but also to see how the private sector funding can be catalytic. But I think that, as you said, we've got, Gavi funds. Many countries are graduating from the Gavi programs. We've got Global Fund. Some countries are getting less budgets. So many of these programs are coming at a cliff for funding as well. And so how does a country pick this up? And I'll stop there and turn that over.
Yeah, just to say, I think that's one of the big, huge issues of the future that you've raised. And I think there's a lot of different ways we have to come at it. One is, do our funding programs provide incentives, carrots and sticks, for countries to really step up? The Global Fund does do that. It withholds part of the grant until a country has shown that it's investing more of its own money in the health of its own people. And in fact, and you heard Michelle Sidibe talk about in the area of HIV, now a majority of the funding is coming from implementing countries. So there is progress. I think, TB is one of those things that affects a lot of middle-income countries, so it's harder. So donors are less interested in going in there, so that's one place to really watch in terms of this. And we have the high-level meeting coming on tuberculosis later this year. I'm thrilled to say that we've really seen India step up in terms of addressing its own TB epidemic, including budget increases. That's the kind of thing we need to broadcast all over the world, so other middle-income countries heavily affected by TB see that and come to New York for the HLM and announce some bold plans and new investments from affected countries. And then I think we need to be funding civil society at a much greater level than we do to be advocates for domestic finance, but also domestic finance that reaches all the people in a country, including marginalized people.
Thanks. I'm tempted to add a few comments myself, but I'd rather have spend the time with our panelists. But I think we have time for one more round of questions. I realize I'm standing between you and another drink, but go ahead, Bruce. Here, let me.
Bruce Wilkinson with CMMB here in New York. Just a really quick question around, we talked a lot about health system strengthening, and our health systems in many of these contexts, what we're talking about are rapidly evolving, whether it's government, whether it's private sector, whether it's faith-based, they're quickly adapting to market conditions, they're shifting their priorities, they're moving very quickly in terms of between personnel, between systems, policies, procedures, looking for cost recovery. So if you could just help us to understand where you think pandemic control is going to actually find its place within the multitude of responses within these new emerging sort of responses in health systems, and how do you strengthen those varied health systems? And I'd love to hear community voice at some point. We didn't see it in the film. We didn't see it in we've got a little bit of that civil society, but community voice and this awareness at the community level, where do you see that moving?
Hi, Iris Mwanza from Bright. My question is for probably Dr. Martin, and it has to do with progress on U.S. government procurement cycles. So even when you're talking about renewals of existing projects, oftentimes there's a gap, and that can be up to, a year, 2 years, and this has implications for, I think, all of the, matters that we've discussed today. So I would like you to, if you could, comment on that, and, hopefully there's some improvement in there.
Any last question we can add to the mix?
This is Fenora Frank from the International AIDS Vaccine Initiative in New York, and I wanted you to speak to, exploitation, both sexual and physical abuse, introduction of disease of intervening groups, and how do you respond to backlash of affected populations, and how do we hold ourselves accountable when there has been cases of that, and then how do we manage that? What kinds of safeguards need to be put in place when we think about intervening in communities?
Back to the panel.
Yes. I'm going to start with just the cycles, though, because I think CDC, our funding is usually very annual. And it was actually this past year, in just this fiscal year, we did get monies that are going to be able to be used for 2 to 3 years. So we have to be careful of how we can use those, but we want to make sure that we can use those as we go in to not have that gap as you're talking about in the cycle. So it's something that we are trying to address, and working with partners, we've been able to also give more than 1 year of funding out to our implementing partners, which has been very helpful in those efforts. But you're right, it's a real issue, and we have to continually deal with that. So I appreciate your comment. Where does it lie? I think there's a lot of places, but I think within the health system, we say that health security is national security, and we want there to be indicators within a national system of what a good governance is in a country. And so starting right at the highest level, it can't be just with the Minister of Health, because Minister of Health is not usually the most powerful minister in the ministerial group. So it's something that we are trying to bring in ministers of finance as well, and the different ministries together, but to bring it into prime minister, president sort of level of bringing this importance that each country has to have this capability and to be able to have the infrastructure, because it's not just in the health system itself. And as you mentioned, and I talked a little bit about our work in the community-based surveillance, but the communities are really critical. we saw that in Ebola and many outbreaks. I mean, now we have many interventions, but if you can't get the community to want those interventions and not understanding culturally about what's important to them or not, it's so very important in the work that we do. But I think it's where we partner with non-governmental organizations, civil society, to bring their expertise and who are working in these communities to create, also as Chris mentioned, the demand for good services and for advocacy. So it's important in those efforts.
No, I really have nothing to add. I just took the microphone. No, but I would say that I agree with everything Rebecca said about this. I mean, and just to amplify it, since I have the microphone, we and I really didn't, but we funded a study that Diane Worth's group at Harvard did on why various states in Nigeria had better responses to certain disease categories like malaria than others. And the fact of the matter is that in Nigeria, in some ways, governors of some states have more power than the president does. So, to Rebecca's point about how you kind of push down until you get to where the interventions are going to really make the most difference, I think that was implied by your question and certainly was explicit in your answer that communities are vital to this. And I think that more and more, it's a challenge to get to the communities in a way that's scalable. And I think so many interventions are designed as pilots and then kind of stop. And so kind of moving it from the exploration phase or moving it out of the lab into a community and then taking those learnings and blowing it up are something that we really have to do a better job at. So I think that's what your question implied, and I would associate myself with that.
I would just mention to your question, talking about intervening in communities and vulnerable people in those communities. I mean, this is one of the really tough things ahead for us in all of these three big epidemics, but in all of health. People who are marginalized are often at greater risk, and they have less access to services for a whole variety of reasons. They may be economically marginalized. And they may suffer great stigma in terms of seeking services. So it is not something we figured out in terms of our global health response, although I will say the United States, many programs really, this is one of the things that's important about our leadership, is that many times our programs will be designed with marginalized key populations thought about. Not that we have the answer to that. Ultimately, as we're moving towards country ownership and country financing of a country's system for health, we also need to be moving towards countries taking care of their marginalized citizens. And that is part of the handoff. How do we do that? You can, as we're doing the country transition financing, can you create requirements that countries invest in responses for key populations? I certainly think those kinds of incentives, there's a kind of a corollary to the domestic investment incentives that we need to be providing. We need to have incentives in place for countries to really come to grips with treating marginalized people equally and getting them the health services they need. And that's going to be a major area for activism going forward, and I think for all of us to be involved in.
Great, thanks. Oh, sure.
I was just going to say, under PEPFAR, we have funding to conduct surveys just to look at violence against children as one of the major factors for looking at epidemics of HIV. And right now, it's more that we have these data, and we're starting now to figure out what to do with them, and to engage. But we have started to look into public health laws, public health regulations, but also looking at what you can do with young men and young boys beforehand. But again, this is still pretty early, but there are the data out there to at least document that there are these issues, and now it's like, what are we going to do? Because it's not enough just to have those data. We have to act on them, and that's what we're working on. But it does, as you said, talking with the government, with civil society. It's really critical, but it is a huge problem.
Well, thanks. Now, we could go on for hours, and this has been a really interesting and stimulating conversation. I just want to say three things and bringing it to a close, and then encourage you to have another drink, talk some more, have some food. But those three things are, first, I want to just congratulate Matt King and the Foreign Policy Association, their colleagues at PBS, for creating such a provocative film that has generated this kind of discussion. So, and I think Mac was telling us earlier that the distribution plan for the Great Decisions films are such that, 95% of people with a television in the US have access to these programs on the PBS network. So, there will be tens of thousands of conversations like this around the country. So I hope that that brings global health to the attention of many, many more people. When Emmanuel raised this question of politics, it reminded me of, some of you know that I'm a recovering academic. I started my career as an academic historian, and I'm reminded of an article I read in Social History. A French social historian, I think his name was François Dagenet, about 35 or 40 years ago, wrote an article that began with the epigram that societies get the diseases they deserve. And what he meant by that, I think, is exemplified by this conversation, that disease and health is not, and healthcare is not just about biology and demographics and epidemiology, but it's also about social relations, it's about class, it's about poverty, it's about marginalization and vulnerability in a society, it's about economics, it's about the private sector and civil society, and it's about politics. Because ultimately the kinds of questions we've been discussing come down to political choices and the allocation of scarce resources. So every society has a different answer to that set of questions. But I think one of the conclusions we can draw from tonight, even though we've only touched barely scratched the surface of the complexity of these issues, is that to get sustainable solutions, to achieve the kinds of health outcomes that we hope to see through the SDGs, we need to have multi-sectoral and multidisciplinary responses that will draw on all of the resources in given societies and all of the expertise that people can bring to bear on these very complicated questions to enable us to stay one step ahead of the microbes, because that's the fight that we're in. And finally, I'd like to just say that our discussion tonight with Rebecca and Jim and Chris has exemplified that kind of multidisciplinarity and multisectorality. We've had we've taken a very quick tour of a very complicated landscape, but it's been really interesting, and I want to thank them. I want to thank, again, the Foreign Policy Association and PBS and Friends of the Global Fight, and I want to thank all of you for coming and for your attention and your questions. So thanks very much.